Welcome to the Allied Health Professionals podcast series
with your hosts Jennifer Trafford
and Alison Kerr.
So today on the podcast we are lucky enough to have the falls team. So why is falls so important?
Well, I think people need to understand the impact of falls. So, for example, it's in over 65s, it's the biggest reason people will attend EDs because of a fall. People that fall and fracture, 10 to 20% of those people over 65 will actually die within the first 1 to 2 months.
That's an amazing statistic, that.
It is, it's terrible, but actually it gets worse because after a year, 30% of those people will have died following a hip fracture. It gets worse when over 75, and then once you hit 85, the statistics go up. And it isn't necessarily the hip fracture that actually leads to the death, it's the fact that they're then less independent, they need more help from care, they acquire secondary injuries, the decondition. It is quite scary. We spend over £4 billion a year in the NHS just on falls.
How much?
Over £4 billion a year is the cost, and that isn't all of it, because they believe there's a lot of hidden costs because of the fact that people don't report falls because they're very worried about it. They think they're going to be carted off to a care home. So the actual cost could be a lot more.
I suppose you'd have to think about the hidden costs would be things like people falling. It knocks their confidence, doesn't it? Which then starts to
100%.
affect mental health, which has an
Absolutely.
effect on other services
Yeah.
that are already overstretched.
Absolutely.
It's a huge thing, isn't
It
it, when you
is.
think about it from that point of view?
And I think we all know about frailty, don't we? Frailty's the in thing, but falls and frailty are absolutely interlinked. So we talk about falls being a syndrome of frailty, but I've got a little patient story for you later, which demonstrates that people aren't frail, then fall, become frail. So it's so important that we manage this early on, and that Kathryn's going to talk a little bit about the prevention, because what we really need to focus on is making sure people don't fall in the first place.
Yeah.
And that's where we're at. And that's probably the main reasons why it's important.
So nice introduction to Kathryn. So Kathryn, what is it that makes people, what do we need to do to keep people active so that we can prevent that type of statistics becoming higher?
It's so important. I think the more that we can sort of keep people active at a younger age, we're talking, falls prevention, we talk about the over 65s, but I think at any age, as people are starting to get older, they need to be that little bit more active. One of the key moments that we all are aware of is if somebody comes into hospital. If somebody's admitted to hospital for any reason, you'll find that an older person in hospital will spend 87 to 100% of their day either in bed or sitting.
Yeah.
Wow.
And they will do about 600 steps a day maximum.
Yeah, that is definitely not hitting any target, is it? Anything.
No.
You can imagine the loss of muscle strength, the loss of joint flexibility, the loss of balance that they will have. But it's not just the physical deconditioning, it's the cognitive deconditioning as well, because they're not planning their daily routines, they're not doing all of the things that they would normally do, they're losing their confidence, they're feeling that they can't do because things are being done for them, because we're caring for them, and that's the natural thing to do. But it's how we can do that in a way that supports somebody to stay as independent and active as possible. And I think it's, we talk a lot about deconditioning in hospital, and it's almost like we point the finger at the hospitals. Actually, what happens when that person then goes home? And what are they then doing when they go home?
So is this where the falls team really comes into its own then?
I think we're double-edged sword, really. So I think inherently we firefight. So we've been in a situation where we get the referrals into the falls team once somebody's had falls. What we are trying very much now with things like Steady on Your Feet and our promotion through our regional groups is what Kathryn was talking about, is that upstreaming, we like to call it. So it's engaging. We work locally with the leisure centres, with the North Yorkshire County Council and Middlesbrough councils, to try and get the message out that you have to take responsibility for your own health earlier on. And another statistic that we had, which I didn't mention, was that, by 2040, it's estimated that 24% more elderly people will fall. So we're kind of inundated a little bit at the minute. So we're trying, aren't we, Kathryn, to try and work regionally to say you need to take responsibility for yourself, because we can't we can't hold hands all the time. So we're trying to promote a healthy aging, activity, like Kathryn said.
So we have sort of strategies across both areas that are really looking at trying to encourage all organisations to work together to make people more active and to think about falls prevention at all points. We've recently done training with our local library services that they're going to be introducing Steady on Your Feet. We've also done some training with some housing services so that they're going to be looking at Steady on Your Feet as part of their sort of annual checks of older people in their own homes, and really making sure that falls is everyone's business. But part of that is, making sure that we are keeping people active, keeping people eating well, thinking about, their medications and how they're taking their medications, and really looking at all those different individual factors.
And I think the key point is if someone's deconditioned before they're admitted to hospital, they're already on the back foot. So, like Kathryn said, if you think about the decline in somebody that's elderly, because I think one of the statistics is that I think a 10-day stay in hospital for an elderly person can actually shorten their life by 5 years due to that muscle mass loss and confidence, psychology of it. So can we have people, if they have to come in, can they be fitter before they come in so that actually we can get them home quicker? And like Kathryn said, it's what happens when they go home. We really need to be, and rehab has to start from the day they come in. We've talked a lot, haven't we, about active hospital status?
Yeah. So we need to think about keeping people active at all points of their health, whatever they are able to do at that moment in time, and how we really don't let them stop moving. They really, really, really need to keep going, keep active at what they're able to do at that point in time. And whether that is, looking after their own medications, whether that is, keeping themselves active on the ward, getting them dressed, getting them moving, all of those sorts of things. But again, thinking about when they go home, we need to think beyond the baseline, and that baseline that they were at when they came into hospital is at a falls risk, and we need to think about what we can do to get them beyond that, to get them as safe and independent as possible.
Can I ask who's involved in the falls team?
From a community point of view, we have a falls team in Hambleton, Richmondshire. We have Kathryn's team covers Middlesbrough, Redcar and Cleveland. From an inpatient point of view,
so what allied health professionals are involved? Like, is it a multi-team, multidisciplinary?
It is.
So we have physios, occupational therapists, therapy assistants working within the falls teams. We also do have very strong links with pharmacists. We find that our dietitians are really, really important because we really need to make sure that people are eating well. If somebody's deconditioning, they're at high risk of sarcopenia, so we really need to make sure that their nutrition is really good. We'll be in touch with our orthotists if somebody needs any specialist footwear or any support from that, our podiatrists,
orthotics, social care, psychology, neurology, because I think what I've learned when I've worked in falls, I'm a neurophysio by background, and use sort of quite narrow tunnel, like it's this, I'm a neuro, but falls covers all multitudes, and we do training on, say, continence, because it has a link into falls. We do nutrition, we use the MUST, we use MUAC, we do lines and blood pressures, because falls is often a little bit of everything that causes the fall. So I think, are quite skilled as in our falls teams and being able to assess many, many avenues of falls prevention, whether that's medication. But I think one of the key things in terms of, because everyone goes, oh, it's exercise, it isn't. It's a whole raft of things that we look at.
We talk a lot about people being active. I think that has to be with that multidisciplinary view. Physios may start the exercise, but the dietitians are going to make sure that somebody's eating well. The podiatrists are going to make sure that their feet are in good condition. The OTs are going to help people to look at purposeful activity and what's their barriers to exercise, and that's really key within our team. So it really is everybody's business.
So Tina, I think we're coming to the end of the podcast, but I think it'd be really nice to hear about a story from how does this work from a patient point of view?
Okay.
Can you give us an example?
So we had a lady who previously had been very independent. She went to bingo, she was dancing, she was out walking. She had a fall, didn't tell anybody. It's really common because she didn't want to tell anyone. She was embarrassed. She thought, oh, I'll be fine. but it knocked her confidence. And because it knocked her confidence, she started doing a little bit less. Because she did a little bit less, she deconditioned a little bit. Her balance then got worse. She then had an episode of dizziness and fell again. So by the time we'd got to her, she'd actually almost become housebound in a very, very short space of time. When I went and assessed her, she did have a particular dizziness problem, a vestibular problem, which we assessed and treated. But I would say the mainstay of her treatment was about confidence building, getting her out and about. Her goal was to see her grandchild, her first grandchild, to be able to go to their house and hold her first grandchild. So that was her main goal. I think over about 4 months, we worked with her. Michelle, who's one of our therapy assistant practitioners, went and visited her. We worked a lot on psychology and confidence building, not just exercise. And she got to walk to her daughter's house and pick up her baby, granddaughter, and she said to us, "You've given me a reason to live again."
Oh, that is motivation enough, isn't it?
Yeah.
It's just knowing that it can have such an impact on that patient. That is so important.
And like I say, she was not frail, but the fall led to some level of frailty, but we managed to reverse that. So, yeah, that's all good.
Amazing. That's an amazing story. Love those stories.
Yeah.
Fantastic. I bet you have loads and loads of those.
Yeah.
Kathryn, do you have any stories that come to your mind?
I think that we always talk about two different types of patients, don't we?
Yeah.
The younger age, but the gentleman that comes to mind for me is a gentleman who has Parkinson's disease. He's at home with his wife. He was falling on a daily basis. He had some cognitive impairment. We did some work with him, did a falls assessment. We did line standing blood pressure with him, looked at some of the medical factors. We had a medication review done by the pharmacist, and we looked at the OT did a memory test and looked at his LACLs, which looks at sort of the cognitive ability. We did an exercise program in line with that. But although his balance and his mobility improved and he was falling less often, it then came to the point of, but he is still having the occasional fall, but it tended to be when he was doing activities that traditionally somebody might have turned around and said to him, "You can't do that anymore because you're not safe to do that anymore." And our viewpoint is, why are we saying that to a gentleman who's for 40 years gone and done some pottering in his garage? Why can't he go and potter in his garage, and why can't we find a safe way? And when I visited him, he actually had a carer sat with him who come to spend some time with him doing a jigsaw. So our OT went out and did some work with him and the carer and looked at actually they could do some work safely in the garage, so that actually he is able to still do what he wants to do, but just in a safer manner.
I love that problem solving. There's always a way mentality that I think AHPs have, and particularly in the falls team. It's that we will find a way.
Yeah.
And I love that.
Yeah.
So we're coming to the end of the podcast. Have you got any key messages or key plugs you want to do while we finish the podcast?
I think one of the things is don't stop moving.
Yeah.
You know, we really want people to be active. We really want people to be moving.
And we're not asking people to go and join gyms
or run a marathon.
Yeah.
And I think like it's activity of daily living. I know we say those words, but and I think again coming back to the hospital part of it, I've talked to Kathryn Hodgson. We've talked a lot about this. It's difficult, isn't it? In a hospital environment, we want to put everybody in cotton wool, and if someone falls in hospital, it's awful. It is. It's distressing for the patient. It's distressing for the staff. But the reality of it is, if we don't let people walk and move, they will fall. So it's managing that really fine balance, but it's all linked to keeping moving.
And that falls really is everybody's business.
Yeah.
Thank you so much for joining us. Look after each other.
And yourselves.